Good evening, everyone. We welcome all of you who are the virtual oral presenters at the Sri Lanka College of Cardiology Annual Academic Sessions 2020. And first of all, I would like to thank, on behalf of the college, for actively participating in by submitting your papers and going through the process with various difficulties due to the COVID-19 challenges that we have faced. Today, to start the competition or the oral presentation session, I will brief you very briefly how it's going to happen, and we have in detail provided you with all this information. Just to recap, you all are already lined up in a certain order, and we have 4 judge panel, and they will be judging you based on each one of your presentations, and you are given 5 minutes each for each one of you, followed by a 2 minutes question time. We have 1 minute buffer time. We will try not to go into that 1 minute, and each of the presenters presentation should be over by 7 to 7.5 minutes time, presentation and the question time. So the judge panel includes Dr. Kumuduni Ranatunga, Dr. Sepalika Mendis, Dr. Mervin Fernando, Dr. Jamal Dean. So all of them are senior cardiologists who are well versed with research, and you are hereby, you will be judged in a very comprehensive way as well as a very fair way by this process, and I wish all of you all the very best, and I will hand over the proceedings to the judges.
Okay, may I ask Dr. M.N. Lansakara to present your case?
So the topic is aortic valve neovascularization.
Not very clear.
For the Osaki procedure in the proximal aortic pathologies, I would like to present 2 cases. So the aortic valve neovascularization with an autologous pericardium, the Osaki procedure, is a well-established procedure, and it was introduced by Professor Osaki to the world. Since then, popularity is increasing gradually. So this Osaki procedure can be applied to variety of pathologies of the aortic valve. It could be aortic regurgitation, aortic stenosis, or combined or mixed aortic valve disease. So we report 2 cases of Osaki procedure in combination with ascending aortic replacement.
Dr. Lansakara, you're not sharing the slides, it seems. Can you, can you share the slides with us? We can see you, but...
Yes. Can you see that?
we can see you, but not the slides. We don't mind seeing only the slides, and if your voice is there, that's enough. Okay. That's fine. That's fine. Go now. Go.
All right. Okay. So we report 2 cases. First one, the case one is a 55-year-old male patient with a history of aortic valve endocarditis. About that, he had presented with severe aortic regurgitation. So the second patient, a 36-year-old female with SLE or systemic lupus erythematosus with severe aortic regurgitation. So the dimensions of the aortic valve on preoperative imaging, first patient at the aortic annulus was 29 millimeters, transsinus diameter was 33, sinotubular junction 29, and aorta was 61. Patient number 2, the female patient, had diameter of 28 millimeters at the annular level, 40 millimeters at transsinus, 37 at sinotubular junction, and ascending aorta diameter was 45. So both patients underwent surgery under standard cardiopulmonary bypass with distal ascending aortic cross-clamping, and both valves were measured with standard St. Jude aortic valve sizes. Both were 27 millimeters, and the ascending aorta replaced with 30 millimeter PTFE grafts in both procedures. So in our Osaka procedure, we size the 3 leaflets. In the first patient, left coronary cusp leaflet was 29 millimeters. Other than that, rest of the leaflets were 27, that is right coronary and the non-coronary. In patient number 2, both the leaflets, all 3 leaflets were measured as 27. So this is, in first patient, this is the ascending aorta. I think this is the heart, right atrium, and this side is the left, right atrium, right ventricle, and this side is the left ventricle. So this is the dilated. I think you can see clearly the ascending aorta is severely dilated. So this is a picture of post procedure where the right ventricle is here and the ascending aorta was replaced with the PTFE graft. So this on the right side of your screen, you see how the pericardium, after fixation of the pericardium with the template, we mark the cusps, neocusps were marked, and then we have to cut. I think you can appreciate the fact that there are few marks here. Those are the exact marks where we take the bites when we suture the new cusp into the aortic root. So this is one of the patient's preoperative echocardiogram. So you can, I think it's very clearly seen here how the cusps are not cropping and also the regurgitant jet. And this is post-procedure after neocuspidization, and all the cusps are nicely opposing to each other with the typical benchmark, and also there is minimal or hardly any aortic lobe regurgitation in the post-operative echo. So in the discussion, AV neocuspidization or the AV neo-Osaka procedure utilizes glutaraldehyde 0.6% to fix the pericardium and to before reconstruct the aortic valve. The ascending aortic aneurysms can coexist with AV diseases and usually treated by replacing it with the tubular graft or valve conduit. In our case, the first option was done because the valve conduits are not available for us.
Only 30 seconds more, go quickly.
No technique, the valve can be reconstructed in the aortic root or within the tubular prosthetic graft. In literature, there are only few cases reported about the surgical procedure combined with ascending aortic replacement. However, the added advantage of this procedure is they do not require warfarin. So, thank you very much.
Excellent work, Dr. Lansakar. May I ask a question? What is the what is the duration of durability of these valves? You know, now they are very young patients, I guess. What do you think is the durability?
2007 to the world, recently Professor Osaki has published his midterm data. That was in last year, 2019. It is pre-operation free is more than 90%. And relatively new procedure, but the advantage of this is we maintain, compared to a valve replacement, we maintain the normal aortic valve anatomy. That is the dilatation at the side between the aortic annulus and the sinotubular junction. The sinuses, the structure of the sinuses are maintained. Because of that, the pressure effect on the aortic valve leaflets are minimized due to the laminar flow of at the level of the aortic valve. So the
in his series, excuse me.
Sorry.
In his series, what is the longest duration? In his series, what is the longest duration of follow-up?
13 years now. Up to now, it is 13 years.
13 years. Okay. Thanks.
Yes.
Thank you.
Can I ask a question, Dr. Lansakar? Other than Dr. Osaki, how many large-scale series have been published so far?
If you go to this AV News, is that the American company they make these sizes actually. You know, like in the valve sizes, we have different type of sizes of the size, so that measures from sinus to sinus. So they have the template after that. So we have to mark accordingly. So this AVNeo website, there are several, more than 10 centers in US, about 10 centers in Europe, few centers in Asia. And I'm fortunate enough to say that our name is also included in the AVNeo website.
Oh,
National
Is it the first case in Sri Lanka?
No, I have done about now 15 plus cases. We are doing these 2 cases with 2 ascending aortic replacement. That is to show that we can combine other procedures of the aorta. And in addition, I have done with CABGs and also with mitral repairs as well. The purpose is to avoid warfarin actually.
Okay.
So we explained, some people agreed, so we proceeded with them further. Recently, I operated on a patient, aortic valve, he vehemently refused Osaki Neo, so I had to replace the valve. So now he's on warfarin, he's a young chap about 45 years.
Are you giving warfarin at least for 3 months here or not? Like other tissue valves? Now sometimes for tissue valves we are giving short duration warfarin. Are you giving any?
Warfarin?
No
warfarin.
warfarin.
Only 6 months of aspirin.
Aspirin, okay. Dual antiplatelets or single antiplatelet?
No warfarin, unless it is a mitral valve repair because of the ring thing. Here we don't use any rings here, only the sutures.
Okay.
Autologous pericardium along with just suture to the aortic valve natural annulus.
Okay.
If it is a bicuspid valve, we have to create a sinus annular level and make it tricuspid. So if it is a bicuspid valve, we can make it a tricuspid, which is, I think, the more natural sort of valve.
Brilliant, good.
Thank you. Thank you very much.
Thank you, madam.
Yeah.
Thank you.
Can go to the next presenter, Dr. C.I.H. Sirivardhana. Dr. Sirivardhana, we can see your slides. You can start presenting. Can you hear us?
Yeah, we can hear. I can hear.
Your voice is not very clear.
Shall I start now?
Yeah, you can start. You can start, but be loud and clear.
Okay.
Can you increase the volume?
Is it clear now, madam?
A little bit. Yeah, we can hear you. Bit louder if possible.
Good evening and thank you very much for the opportunity. So, my research paper is on Eden's predictions and clinical outcome of consultative neuropathy among patients and coronary symptoms with intervention for elevated myocardial infarction, and I do not have any potential conflict of interest. To define CIN, we did 2 sampling, one at the baseline and one after 48 hours. And if there's an increase of creatinine more than 25%, or if there's absolute rise more than 0.5 milligrams per deciliter, both are taken as having CIN. And according to the literature survey, CIN has many adverse consequences, such as higher mortality rates, prolonged stay in hospital, other cardiac complications, and worsening of chronic renal failure. So having that on mind, we designed our study as a single center prospective one, enrolling 237 patients who underwent primary rescue or pharmacoinvasive therapy for ST elevated myocardial infarction. So those who are under 18 years of age and who are diagnosed with end-stage renal failure, who has a previous recent exposure to contrast, were excluded from the study. So these are the demographic and clinical characteristic of the study. As you can see, the contrast nephropathy is associated with advanced age, diuretic therapy, GFR less than 45, with a statistical significance. And the occurrence of cardiogenic shock and heart failure is more in CIN group, whereas Mehren score reflects the CIN occurrence with a statistical significance. And we saw that the rescue PCI arm had more CIN incidences compared to the primary. At the same time, in the CIN group had a longer duration of stay compared to its counterpart. So this is the first study done to assess the incidences of CIN in Sri Lanka. So it was estimated as 11% in our study. And secondly, the CIN was associated with increase in hospital morbidity by means of more cardiac complications, more cerebrovascular events, and the heart acute renal failure requiring renal replacement therapy. So why this study is important? Because firstly, it showed some demographic data of current study STEMI population having the mean age of 52, and in this study group, smoking remains the major risk factor despite legal measures implemented. And secondly, the contrast nephropathy in STEMI group is the incidence of 11%, and it happens irrespective of the normal creatinine values even at baseline. Secondly, the contrast nephropathy has a higher impact on estimated healthcare spending, partly because its effect on the longer hospital stay, and the other thing is that it influences the hospital morbidity requiring repeated investigations and some special therapy like hemodialysis. However, in our study, the mortality rate of the CIN population was 0%. So moving to the risk factors and the clinical predictors. Risk factors were the age, contrast, volume, and the established kidney disease with low eGFR were the main risk factors that were associated. However, in our study, there was no association, no significant association with contrast nephropathy with diabetes or metformin therapy.
You have to change the slides. Dr. Sirivardhana, I think your slides are not changing.
Go to next slide. Go to next slide.
You are still at the
Slide 4.
4. Are you correct?
Go to presentation mode and go to slide 5. Okay. Yeah, go to next one. You presented this one.
Now we can't hear you. Yes, okay.
Moving to the risk
Okay,
factors and the predictors. Clinical predictor, Mehren score reflects the occurrence of CIN with a statistical significance that can be used as a tool to identify high-risk individuals. At the same time, the contrast nephropathy was more in the rescue PCI group. So that we suggest more to improve the number of primary PCI procedures for a better outcome. We had few study limitations as well.
Your time is up, but we can give you 30 seconds more. We can give you 30 seconds more because of the interruption. Quickly.
One is the confounding effect between the other one is that the development factors like cardiogenic shock affects the AKI, so they might influence our final clinical. So to conclude, the incidence of contrast nephropathy after primary and rescue PCI is 11% and it occurs irrespective of the baseline creatinine level. Contrast nephropathy is associated with increase in hospital morbidity, longer hospital stay, and estimated high hospital expenditure. Thus, high-risk patients should be identified and treated with recommended preventive measures where possible. Thank you very much.
Okay, thank you very much. Dr. Sirivardhana, were there any diabetics in your study? What is the percentage of diabetic patients? Did you exclude them or? So there was no, relationship with AKI with diabetics? Did you look?
Diabetes isolation per se does not have any.
So any subgroup analysis with the diabetes and the have you do a subgroup analysis for the diabetes and the non-diabetes in your study group?
That's what he said.
Yeah.
Diabetes per se.
Yeah.
Diabetes itself did not have any association.
Can you tell us what were the associations? Like, have you found any new associations other than what has been already found out by previous studies about higher incidence and of AKI in contrast given patients?
Most of them are previously identified the association, madam. But in addition to those, the new thing was that it was associated with rescue PCI2 than the primary PCI2. So that was not previously investigated and not documented.
What do you think is the reason? Can you think of?
That's for understanding. Yeah. We don't know the reason. We don't know whether it's due to the thrombolysis itself or due to the prolonged fasting that because we keep the patient for some time and get the patient for the procedure. Whether the volume contraction causing the contributing to the AKI. So that actually I think more researchers are needed to investigate that. And at the same time, I think more strategies are needed. We have to think of more primary PCIs and the rescues in view of reducing contrast nephropathy.
Actually, can I say something? There are so far there are two recommendations to reduce contrast-induced nephropathy in normal populations. Right, the two recommendations are adequate hydration and prolonging the two interventions. Like if you have one intervention gone and prolonging till the next intervention, so that you are exposed to less amount of space the two procedures. If there are two procedures and hydration, that is for any patient who's going to get contrast to prevent contrast-induced nephropathy. So,
I think our time is up now. 8 minutes. Thank you very much for your presentation.
thank you.
Yeah, good study. Thank you. The next presentation is by Dr. C.P. Vikramarachi. Are you ready? The third presentation. Dr. C.P. Vikramarachi.
Hello, good afternoon, ladies and gentlemen. I'm Dr. Chintaka Vikramarachi, Senior Registrar in Cardiology. Hope you can see my presentation there.
Yes, can you go to the slideshow?
Okay.
Yeah. Okay, carry on. Your time is running.
Right. So I'm going to present to you my case. It's a nightmare case at CAT-LAB. Successful coronary interventions for catheter-induced left main and left anterodorsal coronary artery and medial AD perforation complicated cardiac tamponade. So, my patient, 68-year-old male, presented with worsening of angina for 1 hour duration associated with autonomic symptoms. And on examination, pulse rate was 90 beats per minute with blood pressure of 160 by 90 millimeter mercury. And ECG showed ST segment elevations mainly AVL, V1, and V4 to V6 lateral leads. Tropoid theta was highly positive, and to the echocardiography demonstrated the lateral wall hypokinesia in first instance. So we proceeded the patient to the cath lab immediately, and the first score angiogram showed there's a 99% stenosis in proximal dominant circumflex artery with thrombus. So we proceeded with primary PCI to left circumflex with temporary pacemaking in situ. So everything went well. So we did the final cine angiogram after performing the Sorry. Hello.
Yeah, we can hear you. We can hear you. Carry on.
Yes. After performing the PCI, we did the cine angiogram. So I'll show the results. So the image after the PCI. But the final study, there's a spiral dissection with this blood left-handed spiral dissection of the left vein and the leg. So what we did was we immediately pushed this pen balloon to the left main to avoid blood gas, but dilate the balloon to the vein, and we did the quick wiring to the without entering the dissection, and we confirmed the digital wiring at this so after doing that, we stented directly the middle AD proximal with 3 by 33 drug-eluting stent with the proximal overlap, another 2.5 millimeter drug-eluting stent covering the proximal left main coronary artery, successfully covering the dissection flap extending from the left main to LA. So this is the image. So after that, there are no further leakage was noted in LAD, and there's a chemistry flow in distal LAD. But you can see the left side image. There are some pinching or compromise of the left circumflex artery ostium. So we consult and we further go ahead and did the kissing balloon technique to optimize the left circumflex artery ostium. But unfortunately, after performing that, we noted there's a slow flow in distal LAD. For that, we have administered intravenous adenosine, and we did some balloon dilatation with LAD, thinking that probably some thrombus particles has gone and obstructing the LAD system. But next in angiogram, we have noted that there's a perforation of the LAD, probably extending the dissection flap towards the mid LAD. There's a perforation, and we immediately get down to water. That period we kept again balloon finale, inflating the balloon with LAD, suppressing the blood loss, and immediately stent that portion with the covered stent covering LAD, that perforated segment. And the echocardiogram shock showed there's pericardial diffusion causing some tamponade effects. So we have immediately removed around 150 to 180 ml of blood from the pericardial sacs, which resumed the patient's baseline status, no chest pain, and hemodynamic patients become stable. Finally, there was no any dissection, no perforations, and patients even stable. So its heart rate become back to normal. So later on, we continue monitoring the patient at HDU, and he needs around 1 pint of blood transfusion. And we have been further monitoring and observing the patients as an outpatient, and patients have been well after 3 months from the procedure, and is on dual and related treatment. So the importance of this case was at any time you can anticipate this type of complications, especially while in primaries, because sometimes you might get some stable plaques.
You have to quickly finish and we can go for the questions.
Okay.
Right, thank you very much.
Thank you.
Right, as a question you can ask the take-home message. Yes, how these things, yeah.
How do you think that you would have prevented this complication in the next case, in another day?
Yes.
What do you think is the reason for the perforation?
Probably there are some unstable plaque in left main and probable some catheter movement as causing the left main dissection. This is the first time we encountered this left main dissection. So it's like we couldn't exactly get a situation like that. There's no such aggressive catheter movements or anything, but later on when we closely observe, we show some left main plaque and the catheter was sticking there, some lost the coaxial movement. Probably that has given rise to that loss of coaxial movement of the catheter causing this dissection in this situation.
Yeah, but dissection I can quite understand, but I'm wondering how the mid-LAD perforation has happened.
Probably, madam, yes, mid-LAD perforation probably due to that we decided to balloon dilate the mid-LAD, thinking of that probable the slow flow was secondary to some thrombus propagation after the kissing balloon technique performing in that particular area. Probably that balloon dilatation might have provoked the dissection flap to propagate and causing the perforation. Due to that,
could it be just dissection flap, extending the dissection flap could have caused this? Or your wire can go into the dissection flap and can perforate.
Yeah.
Yes, that is also that's also one possibility.
Only dissection
could be the reason, because that all the everything is like we have to address like a fraction of a minute. So sometimes the wire has gone through the flap and cause the perforation.
Yeah, it is great that you saved the patient's life. Is he all right? What is
Yes.
the follow-up now?
Follow-up now, patients have been, we have been following up like almost 4 to 5 months. Patient doesn't have symptoms or anything currently, but in case like we know that we
have you did a check angio for this patient after 3 months? Yeah.
No, sir, we plan to do because
Don't you think it may be necessary? Yeah.
It will be necessary because we have inserted the power cell and there's possibility of power cells in those sense that even there's a like.
Other one last question. In the angiogram, have you detected any plaques in the left main before this causing this catheter problem? Have you noted any left main disease?
Initially,
in the angio?
from the beginning, this left main looks almost like normal, but later on when we analyze further, we notice some minor plaques in the proximal left main. But
so the message you have to think is they have tubular plaques. Sometimes from ostium to the distal you will have plaques, but as if it is a uniform and tubular plaque, you will not think this could be a normal left main. So that is some tricky situation you can see. So so you have to consider the diameters of the left main as well compared to the left anterior descending in future cases.
Exactly. Yes, exactly.
We have done the repeat angio and showed us.
Okay, yes, sure, madam. We'll do the repeat angio. Thank you very much.
Thank you very much.
May I call upon Dr. Lansakkar to proceed with your presentation? Dr. Lansakkar.
Hi. Good evening, ladies and gentlemen. I am Dr. Nalaka Disanak. I am cardiac surgeon from Kandy. I am working with Dr. Lansakara, so I am going to present this case. Our study in Kandy, the approach to mitral valve endocarditis, single center, single surgeon study. So as you know, the mitral valve replacement is a traditional approach for infective endocarditis, although the repair is the norm for degenerative mitral valve disease. So it is a challenge to make in the setting of endocarditis because we will encounter variety of lesions. So here we analyze the different approaches that we have adopted to perform a such successful repair in a above situation. So method, this is a
Your slides are not moving. Your slides are not moving.
Sorry. Slides are not. Awesome. Can you see this? Is it clear for you guys?
Yes.
We are starting again.
So this is a retrospective analytical study that we have performed from the cases done from 2011 to August 2020. A total number of patients are 23 and surgery was performed by a single surgeon. So we have analyzed the location and nature of the lesions, techniques that we have adopted, and also the outcome. So our norm was to repair the mitral valve in every single case. So we have done intraoperative assessment of the success of the repair with the TOE and the saline test, and we have managed to repair the mitral valve in 95% of instances with only one case being failed. And vegetations of basically the P2 and A2 are the most common lesions that we have found, followed by leaflet perforation and caudal rupture. So the repair strategies that we have adapted, basically all 22 cases that we managed to repair, we use annuloplasty ring. Then we perform pericardial patches in about 3 cases, and folding plasty, that is folding of the leaflet, in 2 cases, and neocords in about 5 cases, and triangular resection of the cord of the leaflet and repair in 3 patients, and quadrangular resection and repair in about 5 patients, and resection and siding plastic in about 8 patients altogether. So this is an example of the lesions that we found in surgery. So this is a mitral valve, this is the posterior mitral valve leaflet. So there's a P2 segment and there's a characteristic vegetation attached to its tip. This is short video demonstrate the echo after successful repair in one case. So our results, basically we encountered only one mortality that occurred 3 days after the surgery due to rupture of cerebral myocardial aneurysm. And all the other 22 patients had satisfactory postoperative imaging and discharge home. So we made this conclusion that successful repair of mitral valve in endocarditis is possible in majority of cases if we tailor the surgical approach to individual patients' pathology found at the time of surgery. So for better assessment, we need long-term follow-up on these patients. Thank you.
Can I ask one question? Of these patients whom you have repaired, of the 25 patients, anybody came back with fever and valve infection again? No one came so far.
From short-term follow-up of our patients, we haven't encountered any patient with fever or valve failure for the moment. And we are still following up some patients, but we are also tracing other patients as well.
So did you get the 3D TOE views or pictures in pre-op or the valve anatomy, the valve morphology? 3D TOE?
Yes, we always perform intraoperative TOE with 3D in-phase view to see
Yeah, in phase view, yeah. Okay.
valve anatomy. Then
I mean,
perform
before the surgery, are you getting you are getting an idea how the valves are, like 3D appearance before the surgery? I mean, preparation, during preparation.
We basically usually get the referral without images. We
Images.
basically rely on what is written.
So your
our
first time seeing the valve during the surgery in the perioperative TOE.
Yes,
during
yes,
perioperative TOE.
our anesthetist is a certified TOE specialist, so he usually does the TOE for us. So we basically correlate TOE findings and intraoperative findings of the valve.
Oh, would like to know the anesthetist's name who is certified for TOEs. Who is the anesthetist? May I know the anesthetist who has got the certificate for TOE? Excellent. Who is she or he?
Sorry, he is Dr. Priyanth Disanayake.
Okay. Oh, good.
Who
So out
is,
of 25 patients, you all have followed up only 10 patients, is that so? Out of 25, only 10 patients, what is the mean follow-up period? Very interesting, that's why I would like to know, because when we have infective endocarditis, it's very difficult for us to send a patient for surgery unless you, cure them, like, fever should settle and the CRP should come down, and it's a bit difficult. So it's very interesting if you are doing it. Yeah. So what is the kind of follow-up period?
So we basically, in terms of surgery, we follow up the patients for about 3 to 6 months.
Okay. Now, what are the difficulties that you encounter while doing surgeries while they are having infection? Because are the tissue friable? Or?
Yes, one thing is it's unpredictability of the lesion, because it can affect different parts of the mitral valve. The second thing is actually the friability of the tissues, and that's why we have to adapt different strategies.
How do you overcome?
So we basically have, a big armamentarium of, types of repair, like resection, like this, patch repairs and neocodes. There are several types of repairs that we try on these individual patients.
Okay.
So there is no single type of repair, fixed one.
Okay.
So we have to
Good.
adapt according.
Congratulations. Good.
What about biomarkers? Do you go by biomarkers now when there are patients who are settled otherwise, but only ESR is high, but clinically okay? Do you sort of take that sort of a patient for surgery? Clinically stable, no fever, still needing, valve replacement or repair. Do you take just if you happen to see one marker is high, is still high, do you take as an obstacle for surgery?
What we perform procalcitonin to see whether there's a sepsis. If so, we will do the assessment and.
Actually, there are times when the sepsis is not controlling. Then we are taking patients with high fever going on because it's not settling. After reasonable length of antibiotic treatment, if it's not settling, they are still coming for surgery.
Yeah, it's an indication. Okay, thank you.
Okay, thank you very much.
Thank you.
Next speaker is Dr. M.A. Naushad Ali. Over to you. We can hear you.
Hello. All right.
Hello.
I'm going to share my slides with you. Are you able to see my slides?
Yes, of course.
Okay. Dear colleagues, thank you very much for giving me an opportunity to present some of the data I have with transcatheter aortic valves performed under local anesthesia. I present this as a case series, mainly exemplifying how we should look at patient-based choice with multiple platforms to achieve good long-term outcomes, and how we are able to avoid peril. Now, why do we need to do this? Because each patient has a variable anatomy and a pathophysiology, and there are different mechanisms with each of the devices. Now, there's a plethora of devices that are available in the market, for transcatheter aortic valves, and of course, each of these things come with a cost label, and availability and operator training and confidence in using each of these techniques is a key determining factor for using these devices. And then we have to marry this with the patient conditions to avoid calamities. So let me exemplify this by showing a few cases that we did recently. Now, the first case is of a 82-year-old gentleman who had a previous stroke many years ago and had previous severe ischemic heart disease and severe calcific aortic stenosis. Electively, we managed to treat this circumflex ostomy with PTI and achieve transient improvement in the aortic valve gradient by doing a balloon valvuloplasty, because he was having syncopal events at that time. Patient was known to have lung disease with FE1 less than 1.2, also known to have myeloproliferative disorder, and on the CT analysis, one of the striking features was the presence of calcific atheromatous plaque at the brachiocephalic junction. Now, what you see here with the arrow is the calcification mark, if you pay attention. Now, the challenge here, of course, for the TAVI patient is to avoid giving a stroke. And then in this situation, I thought, a costly procedure, trying to juggle with multiple, clinical safety endpoints. We would prefer a hyperflexible valve system, for delivery to the aortic valve in this situation. So we used my valve because we did not have a single device available for interpretation here. So what you see here is the valve coming across the aortic arch on fluoroscopy, and then note that we stop gap near the plaque for a few minutes, and then achieve complete flexion of the device, because this is a very flexible system, easy to flex, bearing the wire and the assembly away from the calcification and the atheroma in the aortic arch, and we easily cross the aortic valve into the right position without too much of a trouble. Now, of course, this is much easier to use than a passive flexion delivery system. Now, the immediate result, what you see here, is very good. There was no stroke or TIA. Post-implant gradients were millimeters mercury, and there was no PVL, and a patient awake. That's very important for us to understand whether the patient has sustained for a TIA immediately on the table. We have followed this patient up for 2 years. Despite his advancing age, he has very good size capacity, still walking hills. And then this is the appearance of the TAVI valve on echocardiography. You see over here the TAVI valve with no aortic regurgitation, and the peak rate is only 11 millimeters mercury, and there's no heart block. So that's an excellent outcome for this. The case that we did with bicuspid aortic valve is the first in Sri Lanka of this nature. Young man, this is the extended indication on FDA that approved last year for young patients with aortic stenosis. Interestingly, he's had right bundle branch block. He's had a previous STEMI and had primary PCI in UK with a reduced LVEF of down to 45%. But at present, he does not have obstructive coronary disease. He has severe aortic stenosis and severe shortness of breath with abnormal bicuspid valve and wide QRSS with right bundle branch block. This is a Sievers 1 left to right bicuspid aortic valve with the calcific raphe which extend into the LVOT. Now you can see on this image, this is the calcific raphe. Now this represents two difficulties for us. One is in the presence of right bundle branch block, you may end up, making the conduction disease worse, and then needing a permanent pacemaker for a long term for a young man. Secondly, of course, the PVL, paravalvular leak risk, is essential. So what did we do? We actually put the height 8 millimeters above the annulus. This is a funnel-like structure with narrowing up at the top end, and we decided to implant the biggest possible valve in this anatomy, so we don't have the evolute Pro version.
How there you have to hurry, please. Your time.
Okay, all right.
Time is,
All right. So what you see here is implantation. Careful select the implantation of the TAVI valve, released nicely, and outcomes are very good. No PVL, no right bundle branch block. He's done very well with a peak gradient of less than 10 meters mercury. So let me rush to the third 82-year-old frail, with one.
Dr. Thaudar, I think you have to give only the conclusion of this third case because we are running out of time. Almost ran out of time. No time at all.
So coronary heights, was implanted successfully. No issues. This is another, beautiful case of TAVI with ruptured delivery balloon, which we managed to still successfully deploy and retrieve the aortic balloon. This was done in UK though. And if you fail to do this, then retrieve it, you will need to get ipsilateral access and then close and then snare this out. So in summary, multiple devices for multiple circumstances can achieve good outcomes, and understanding the patient's most pressing concern is the key. Thank you so much.
Thank you for your presentation. Good work. May I ask, is MyValve FDA approved?
It is a CE mark approved, used only in situations where, because of the cost concerns that we have, and the outcome data has been presented in Europe, and then now it is a ESC registered valve which has good long-term data.
Your last case was in UK, wasn't it? You said last patient?
That was Edwards Sapiens 3.
It was not MyValve. It wasn't MyValve. Okay.
It was a Sapiens 3.
Okay.
Out of curiosity, what kind of a cost will it involve to get it done in the private sector?
It is dependent on the valve. Of course, I think the co-valve, or the Evolute Pro, I think cost around 4.2 million. I think, if I'm not mistaken, might be higher at the moment with the dollar rate. But
no, I think it's only for the valve. For 4.2 is only for the valve, like with accessories and all the other costs.
Accessories and manpower, of course, we actually did free of charge, you wouldn't believe, so because of the patient's requirement for the treatment, we did it free of charge.
So is there only
of course the MyValve costs a lot less in this situation, and of course if it's approved for long use, I think it might be a better choice for Sri Lankan context because the cost concerns are real.
So selection of valves, only the determinant factor is the cost, or these MyValve and the cost?
Anatomy, as I told you, the anatomy flexion, I told you the flexion system is very good for certain devices, but the co-valve, the Evolute valve, has a passive flexion mechanism, and it doesn't have
hyperflexible. Okay, the third case, the ruptured balloon. What do you think? What is the reason in that case?
That is mainly because of the patient's calcific anatomy, and if you have a jagged edge in the aortic valve leaflets, the moment you do it, like a coronary balloon rupturing, you can actually pinch through the balloon. But it is very important to have very good reflexes here.
So have you done these CT aortograms before the procedures?
Yeah, of course. Every patient with
every case,
will have calcification, but you cannot predict the rupture of the balloon
Balloon,
in this
okay.
situation. It is only at the time of deployment you will know whether the balloon is rupturing. But the key message here is to keep going. You must, deploy the valve to the best possible, level if you are using a balloon expandable valve system. And then if you did that, the chances of you embolizing the valve is lower. And then you can, by your time, you can get another access and go back and then finish and then optimize the valve and then also retrieve your valve.
Did you do that in this case? Because it's a bicuspid
Yes.
ruptured balloon, chances of paravalvular leak is very high.
Bicuspid is rupture. The ruptured bicuspid was not a rupture. Bicuspid was successful, no issue. This
It was
standard-
successful. Okay.
Yeah. Bicuspid excellent. There's no problem. First 3 cases were done in Sri Lanka were fantastic. There were no concerns. 2 years now we have almost followed up all 3 cases and doing very well.
Yeah, our cases are also doing very well. We have done 3 cases.
Yes.
All are, doing very well. Yeah.
It's wonderful to know.
Okay, thank you.
Thank you.
Thank you very much.
Now, Shardali, are you with us again? Dr. Lansakkara, are you with us? You can go to the next case, Dr. M. N. Lansakkara.
Can you see the slides? Can you see the slides?
Yes.
Good afternoon. I am Sahan Naluvihare, Senior Registrar in Cardiothoracic Surgery. My topic will be on effect of internal mammary artery graft preparation by organ bath technique with the usage of verapamil GTN solution. So left internal mammary artery is one of the commonest graft we use in CABG because due to several reasons. One is the long-term patency, and we consider left internal mammary artery as a live drug-eluting stent. So during harvesting of the left internal mammary artery, there is a high risk of perioperative spasm due to various reasons. So in that case, during that situations, we use various types of pharmacological solutions to relieve the spasm. So our study was focused on using computation of verapamil and GTN solution to relieve the spasm of the left internal mammary artery by using organ bath technique. So the combination was made by a medical officer in high sterile conditions. A scrub medical officer made the solution. Usually we use verapamil. Hello. Yes, can you hear me?
Yes, of course, you can go on.
Verapamil 5 mg, GTN 2.5, heparin 1 ml to 100 cc of wrinkle lactate solution, and then we buffer that solution using sodium bicarbonate to a pH of 7.4 to 7.55. So our method, we have done this study started from 5th of January 2018 to 30th August 2020, and internal mammary artery was harvested as an inside the pedicle graft. You can see in the pictures, the diagram pictures, how the internal mammary artery is harvested. This cord-like structure is the pedicle internal mammary artery. After that, what we do is we measure the flow rate of the internal mammary artery in 2 occasions. First, before applying the verapamil GTN solution, we measure the flow rate to the graft, and after that, we submerge the graft in a 20 cc syringe with VG solution for 5 minutes. So you can see, we take the VG solution with a closed pit cap of a syringe, and after that we submerge the graft in that solution, and we replace this syringe in the left pleural cavity just above the hilar region. So our main aim is to keep it in a vertical position so that all the graph will be submerged in the solution. And after that, so we measure the flow rate of the internal memory artery after preparation. So we have taken 153 patients, all the routine cases. In the urgent and emergency cases were excluded from the study. And as you can see, the mean flow rate was before application of the solution was about 50 ml per minute, and it has significantly increased up to 22.9 after application of the solution. So there's a 52% improvement of the flow rate after treating with the VG solution of the treated group. So here, as you know, that we use the Hagen-Poiseuille fluid dynamics. So the flow rate through a tube depends upon many factors. The mean arterial pressure, mean arterial pH, nasopharyngeal temperature, and viscosity of the blood. We try to manage in a accepted range. So as you can see here, though it is difficult to maintain the mean arterial pressure and mean arterial pH in a acceptable range, the flow rate has increased after application of the VGS solution. Now, according to
your time is up. Dr. Sahan, your time is up. Your time is up. 5 minutes gone. Can you give the conclusion? Yeah.
Yes, right. So in conclusion, what I can say is VG solution by organ bath technique for internal memory artery preparation has significantly improved the flow rate of the graft. So the synergistic effect of verapamil and nitroglycerin on relieving the spasm is important here. And also the organ bath technique, by usage of organ bath technique, the graft is exposed to the solution, to reduce spasm. Okay. Thank you.
Thank you. Dr. Alvihari, how long did you submerge the graft in the bath?
5 minutes.
How many minutes?
5 minutes.
5 minutes, okay. Now the control, which you did not submerge, did you measure the flow difference in those non-submerged grafts as well?
Not yet. We have measured, but it is subject to actually from person to person. It varies well. Even for the patient, we have taken one patient at a time and measured the flow rate before and after application of the solution. We have not compared with the other patients. So
because if you just need
the flow rate of one patient to other patient.
Because if you dissect and leave it for, say, the control group, if you leave for 5 minutes and measure, there might be a difference. No? There might be an improvement in that group as well, probably, if you check. You might find the difference.
Yeah, we are in the process of doing it, measuring.
Okay, thank you.
Has it done as a routine procedure nowadays, or this is just
routine procedure?
It's a routine procedure now.
Yes.
Okay.
Now, and when you do that, Dr. Sahan, when you do that, what you really trying to achieve is it your long-term results on the Lima graft, or the short-term, sort of technical, sort of putting the graft and, sort of when the artery goes into spasms, does it make your life difficult to do the surgery, or we were mainly trying to achieve the long-term results?
Mainly, we were trying to achieve the long-term patients, and the other thing is now verapamil this papaverine was used for a long period of time. It was used for about 5 decades now. So it has so the Indian acidic medium, it has some detrimental effect on the endothelium. That's why she started using this verapamil GTN. So verapamil GTN solution, on the other hand, has a very fast act on the graft, on relieving spasm, as well as by adding this verapamil means dilate for a
long-term research.
Yes.
So is it practiced in other countries or other centers?
Yes. Now this first time, first was published in 1989 in England, New England Journal of Medicine, and after that in the Cleveland Clinic, they have recruited about 1,060 patients, and they have done in 2009 another study they have published. So this is used in various other countries also.
Any other bad effects of this? Any unexpected worst outcomes by this combining these things?
At the moment, no, sir. But the thing is, this verapamil, instead of verapamil, if we can use nifedipine, it is more effective because patients who are in beta blockers for a long period of time, most of the patients are in beta blockers for a long period of time. So when we use verapamil, there's a chance of getting heart blocks and so on. So we have not encountered those complications, but still. So yes, still it is good if we can use the nifedipine like that.
Have you used papaverine instead of?
Yes, papaverine we have been using for some time, and after that we stopped using it because the papaverine has a very acidic. Papaverine hydrochloride has a pH of 4.4
Thanks. I think I missed that point. You mentioned it earlier. One more point. I think all what we are doing is to prevent immediate complications, isn't it, Sahan? Because this is not going to give long-term benefits, but patient's outcome is better in the immediate peri-op period if you have a very good functioning lima, isn't it? This is not going to have long-term effects as such, isn't it?
Papaverine, yes, it
Not
has
papaverine. I'm talking about your technique. It will give a good outcome in the immediate peri-op period, right? So that the vessel won't go into spasm in the immediate peri-op, isn't it?
Yes.
Thank you.
Thank you very much. Shall we move to the next presentation?
Naushad, you can do. There you go. Yeah, there you go. Right. Naushad, that's clear for us. Now we're going to show the presenters. Do a full screen. Right. Naushad, you can take your session now.
Can you all hear me?
Yeah, I can hear. We can hear you.
All right. Is that okay to go ahead?
Yeah. Naushad, just reduce the. If you can mute the volume from the laptop. The laptop volume, just mute it. There you go. Right. Now you can start your presentation.
All right. Good afternoon to all. Sorry for the inconvenience. I'm going to present what audit I have involved in my center is City Hospital, Birmingham. This is about the outcome of unprotected left main PCI. To go in, just to make sure that I don't have any conflict of interest to declare. And just to overview about the left main disease, as you all know, this is the left main disease is associated with significant morbidity and mortality. CABG has been the gold standard for the left main stem disease, and
the PCI has assumed a more prominent role in the recent past in treating left main disease. For the aim of the study is to analyze retrospectively the outcome of left main PCI. Just to overview how we did this study, the audit period was January 2017 to June 2019. These data is collected from British Cardiovascular Interventional Society data, and the total participant of these 414, and the case and the procedure notes was taken from the software here in Unity CSS and Metcon IT here. And of course, the death registry was taken from CDA and Unity Now system. Right. To go into detail, we have analyzed many factors, mainly for the demographic features. Of here, we have included over 90 males and 24 females. Out of those who had diabetes, 31, hypertension, 61, smoker, 21, and peripheral vascular disease, 17, and CVA. No one didn't have a significant stage 4 or 5 kidney disease prior to this procedure. When you compare the age range, if you can see, majority of them were between 16 and 80 years of age, and almost all female were between 70 and 80 years of age. And the mean age was 68.37 years. We looked at the underlying LV function. The LV function was normal in 52. That was about 46% of the study. And the mildly impaired was in 24. And the moderate impaired in 15 and severe impaired was in 18. That of course it was done during the in-hospital stay also. And there was in 5 patients it was not available. That of course they were ended up with the significant morbidity, and some of them were dead during the post-procedure. And actually, we looked at the admission type that, of course, significantly contribute to the outcome of the success of this procedure. So, 17, that means 15% of the patients were admitted as an acute coronary syndrome, and the rest of them were in the stable conditions or as an elective procedure undergone to this. Just to remind about this syntax score before going into this syntax score, of course, it's a mild, moderate, high syntax score. They carry a significant poor outcome when you compare the low syntax score. This was published in the European Society of Guidelines in 2014. So we looked at the syntax score as well in our population, the patients. The 40 patients were the high syntax score, that was more than 32. And of course, this high syntax score was associated with a significant poor outcome, as I told you. And this was these patients were undergone to PCI because of the surgical contraindicated in the background of significant COPD and pulmonary hypertension, and of course the patients they were not declined the CABG offers. That's what they had gone for the PCI with the high syntax score. So coming to the
Naushad, you have about only 1 minute more. Only 1 minute.
Majority of them were in the left main bifurcating lesions, and the procedure technique was used in the provisional stenting in majority of them, with 88% patients were. And the upfront two-stent strategy used in 15 patients, and you can see these the different type of two-stent strategies we used. Coming back to these, coming to the follow-up, it was 579 days of mean follow-up. The outcome was 5 deaths occurred during the procedure. All 5 patients were admitted as a primary PCI alert. with the context of cardiogenic shock, and two of them were running with a high degree AV block, and one at the ET arrest, and one died at the ITU stay in follow-up. And of course, there was another death occurred in 12 months from the procedure, but of course, it's apparently it ended up with there no cardiac causes and like that. And during the first 6 months follow-up,
Naushad, your time is up. You have to come to conclusion now.
The conclusion I would like to highlight here. The unprotected left main stent PCI now sentates we consider as a safe and then effective when compared to the mobility and the target vessel revascularization, which occurred only in 7% of patients in 1 year of follow-up. Which is comparable to the national registry here, which was published in 2014 JACC article, saying that these figures are really comparable in the national registry. Thank you. Hello.
Yes, good. Usually, as you mentioned, unprotected left main, the syntax score you have gone above 32, and it's bypass CAV cabbage is the best thing. But you have shown that is it safe in this scenario, and 5 days as the percentage it is low. So this is I think is an audit you have done. I mean the collected from the resource.
It's a retrospective study, basically an audit, including about 114 patients. Out of 114, 5 deaths occurred. All 5 were ended up with the cardiogenic shock. And of course, 7 ended up with the later on ended up with the bypass surgery because of stent stenosis and involving both LAD and circumflex. And one ended up with the PCI2 ostial circumflex disease in second 6 months of follow-up. And of course, I didn't have time to say that 7 patients again ended up with non-STEMI, but apparently the angiogram later on showed it was not related to the previous stenting. That was some other lesions, and out of 7, 4 undergone for RCA stenting and 3 were managed medically.
What made you to do this research? I mean, what made you to
because this is the main disease. Of course, this cabbage was the gold standard way of treating this kind of patient in the past, but now the recent past, because of improvement in the skills and the way of managing the patient, left main stenting become popular, and also we had to in our center we are doing a significant number of left main stenting, and we actually wanted to review how these patients are doing after the procedure, especially so 1 year.
Has this data
because we are continuing to follow these patients.
Has your data are comparable to the surgeon's point of view? I mean, they are having their own perspectives about because the guidelines for this high syntax score and their unprotected left main especially. Is it comparable to the surgeon's? I mean, the study results, and is it comparable?
I'm not too sure about it, but it's comparable because these high syntax patients, of course, although it is said that they will do better with the bypass surgery long term, but because of these underlying surgical contraindications, like as I said, in significant COPD, the pulmonary hypertension, and other comorbids, and of course the patient preference, the only option is remaining for them to go for a PCI in those cases.
Taken.
And of course, they are doing really well in terms of the PCI.
So, do you have any questions? This kind of researchers, has it done before any previous studies, like to show these unprotected left main is I mean, more favorable outcomes?
This was done by one of the Chris Kane and Sammy is and his team. It was published in JACC in 2014. that was that number was nearly 5,000, and they actually the outcome is more or less comparable with our percentage wise. So that's what we actually
So
wanted to do in our patients.
has it been challenged by these surgeons, cardiothoracic surgeons, these outcomes, or not? Are you aware about that?
I'm not
The
really
results?
about this. Yeah.
Okay. Okay.
But I hope so. Yes.
Yeah. So, what is your recommendation as a cardiologist?
In my opinion, is left main stem could be managed with the PCI with the available sophisticated these treatment modalities like is rotabation and the IVUS. There is the evidence or the study showed that patient who are undergoing with the PCI to left main stenting with the IVUS type, they do better.
Okay. So, has
So I think in
using
future
OCT?
might be benefited in PCI.
Have they used OCT here, only the IVUS and IVUS technique only?
They're using IVUS and OCT both,
Yeah,
depending
okay.
on the underlying angiogram findings.
Okay, right. Okay, thank you very much. I think your time running out of time. On behalf of team, I would like to thank all the speakers and the winners. The first, second and third place will be announced tomorrow at the end of the program or end of the session, day 2. So thank you very much for all the participants on behalf of the panel judge of panels. Thank you. Excuse me.
Yeah, thank you very much all for that active participation, and really appreciate on behalf of Sri Lanka College of Cardiology. And I'm sure each one of you would like to know who are the winners. So we will be selecting 3 winners, and the judges will be doing it independently immediately after the presentations now. And the winners announcement will be tomorrow, and through the virtual platform, if you can access, you will be able to get to know it real time. Thank you very much.